Good morning. I'd like to thank the program committee for inviting me to give this presentation on this curious topic against a formidable opponent. I have no relevant disclosures. We have to start by talking anatomy. In order to discuss anything about central veins, we need to really have a good understanding of the terminology and the anatomy. Now, for the purposes of a debate on surgical versus endovascular techniques, we really can only be talking about subclavian veins, and that's what I'll focus on today. Carl is the world leader in thoracic outlet obstruction clinical science, so I've got my work cut out for me. This is a Samson versus Goliath situation, but I'll do my best. A few stipulations. Angioplasty is first-line therapy, I think, as far as most of us are concerned. I can't talk about drug-coated balloons, flow reduction, or pacemakers and defibrillators in this talk. Really, the debate question is if and when to escalate from angioplasty to surgery or a stent. And when I use the term stent today, I'm talking about stent grafts. I don't believe there's any role for bare metal stents in this situation. There's classical thoracic outlet syndrome, which is what Carl is the world expert on, and we know that that results in venous obstruction with abduction of the arm. There's anatomical reasons for this, either congenital or acquired, but it is a anatomical problem in the subpectoral costoclavicular space. And here's a great example of a moving case that Carl worked on a few years ago, a young woman who was a championship swimmer who lost function because of TOS and underwent rib resection and came back to be a national NCAA champion swimmer. And this is the type of patient that benefits from treatment for classical TOS. I submit that's not the same thing that our dialysis patients have. These are our dialysis patients. They're not championship swimmers. They're older, they're sicker, they have more comorbidities, and they have a different pathophysiology altogether. They also have typically high comorbidities, impaired functional status. 5-year survival of a dialysis patient is about 40%. And I think the pathology here is vascular, not primarily anatomical. Now, there are a number of reports of the outcomes of rib resection for subclavian vein stenosis in patients with dialysis access. Carl's the author of several of these. They're all small, uncontrolled series. They describe good immediate surgical outcomes, but the morbidity is not trivial. But they're all combined or mostly combined with endovascular procedures at the time of surgery. They are not curative. There's a substantial need for reinterventions, either angioplasties or stents or surgical revisions, and there's no stent comparator group in any of these studies, so we really don't know how they compare. Here's an algorithm in a surgical journal which walks through this very nicely, although it doesn't really even talk about stents as an option, so I would submit this is an incorrect algorithm, and that really need to include more thought into how and when to utilize stents and stent grafts. Why is this area so hard to treat? Well, there's a lot of heterogeneity in the veins in terms of the patterns, combinations, anatomical variations, and a lot of this is spelled out in our interventional radiology publication on standards of reporting. But I'm going to John Ross it here. I just want to show you a variety of central veins with different anatomical problems, which sometimes aren't even problems if you look carefully. And each of these situations is a different anatomy, it's a different problem to solve, and it's very hard to put them all into one group and compare them as central venous stenosis in various treatment protocols. Last year I spoke about this RCT, gold standard or fool's gold, and I talked about a number of well-done randomized controlled trials that have been done in vascular access over the years, and most recently the Merit Wave Rhapsody trial, which to their credit included a central vein stent group, which would have been really nice to see, except that had to be withdrawn because there were just impossible to enroll patients due to the eligibility restrictions. So that study isn't being done. So all we have are uncontrolled studies of stents for central venous stenosis, a variety of them. I've just got a smattering of them here. I'm not going to go through the Kaplan-Meier curves today. You're welcome. The results are all pretty much the same. They show certain outcomes with stents or stent grafts, but there's no meaningful comparators in terms of controls. And so it's very hard to know what to make of these trials. They've been good enough for the FDA to approve the wall stent and the smart stent for central venous stenosis, which is remarkable to me. That's a different era. There's now some FDA hysteria, which will prevent that from ever happening. I don't think there will be an RCT for CV stenosis in our professional lifetimes. It's very hard to find eligible subjects. The lesions are so heterogeneous that it's hard to find comparable lesions. The sponsors aren't going to support a trial because the risk reward is pretty low in this area. But if one was done and you scrap bare metal stents, no pun intended, then you're dealing with the question of stent graft versus rib resection. And, there's all sorts of things one would want to look at, but if you compare, I think in terms of procedure outcomes, complications, morbidities, costs, requirement for post-procedure interventions, patencies, and patient satisfaction, it's very possible that stent grafts will come out ahead of surgical intervention. Here's a typical patient with severe left arm venous hypertension from left subclavian vein stenosis. He also happens to have cephalic vein stenosis. I think it's very important to get precise measurements, determine the dimensions of the lesions, and this space in the costoclavicular space is rather small, only 10 millimeters, and really no point in putting a 14 millimeter stent in there. It's only going to cause trouble, crushing and crumpling. So we chose a 10 millimeter Viabon stent graft that's draped from the cephalic vein into the brachiocephalic vein, and elephant trunk style. And over 4 years later, with no interventions, that has remained patent. And if you look over 5 years, there were 9 interventions, the stent graft was placed, and over 4 years, there were no interventions, and the patient died. And this is this equivalent of an N of 1 clinical research trial. The patient serves as his own control, and one can actually do statistics on this and determine if this is a significant difference. I think it probably is. Here's a case just last week. I bring this up just to indicate that this is so common. And here's a guy who had similar situation, just right subclavian and brachiocephalic vein stenosis. Now, this has been rapidly recurrent, less than 4-month intervals. It's an elastic lesion, so even after 14 millimeter high pressure angioplasty, it tends to recur quite quickly. He's obviously highly symptomatic, and he has a good graft that's functioning well, and his flow is reasonable, about 1,500 ml per minute. He's 76. He's got mild dementia. He's non-ambulatory. He's in a long-term care facility. These are already very poor prognostic factors. So to put this guy through rib resection, I think would be absurd. So we did what I call precision stenting. Again, we measured this very carefully, identified the length and the diameters we might need to use, and chose an 11 millimeter by 50 millimeter stent graft. I'd submit that many people would have chosen a much bigger stent graft there, but once again, I don't think bigger is better. And in terms of the principles of stenting, besides bigger isn't better, I would submit that there's really only one chance to do it right for the first time, and at the right time, the right place, for the right reason, with the right device. And it's really important to be precise. I think measurements are crucial. So in conclusion, I'd say there is no high-level evidence to guide these treatment decisions. I think it's wrong to extrapolate data or guidelines that apply to different patient populations with a whole different disease process. I would be wary of small, uncontrolled trials. If you do stent, I would practice precision stenting. I would measure, and get it just right. I would not embark on any irretrievable interventions lightly. Once we put a stent or a stent graft in, it's there to stay. It's not coming out. If you got it right, that's great. If you got it wrong, you're kind of screwed. And I would track results by individual patient response. If you can monitor their frequency of interventions before and after your rib resection or your stent graft, then I think you can make sense of what you've done and have some data that will help you interpret your results. Thank you very much.